Go. Hi, everyone. Welcome to our multimodality imaging lecture series. It's a great pleasure to have today Dr. Michael Blacka, who is someone that I personally admire a lot. So everyone knows him for his big career in calcium scoring in particular, but it's someone that I follow since I was a fellow on his publications a lot. So it's an honor to have you here today. So Dr. Blacka did his MD and an MPH in epidemiology at Vanderbilt, and then he completed his internal medicine and cardiology fellowship at Hopkins. He's now an associate professor at Hopkins, and he's a director of clinical research for the Cicurone Center for Cardiovascular Prevention. He has over 600 publications. He's a PI for the CAC Consortium, and he has published in all the major journals, including JACC Imaging, multiple papers, and he is now receiving a very important award from the SCCT for the Agathon Award that he will be receiving in July in Vegas. So thank you very much for joining us. It's a pleasure to have you here, and we're looking forward to your lecture.
Well, it's such a pleasure to be here. I love speaking to multimodality imaging audiences and thinking about really the interface of preventive cardiology and imaging, right? Because I first and foremost consider myself a preventive cardiologist, not an imager, although I do imaging on a daily basis. But I think the point of the lecture will be here today is how does the interface between preventive cardiology and imaging, how does that look, and where do we stand, and then what are the future research topics? I'll try to talk about what the guidelines say, and then as I mentioned here, since calcium scoring is now endorsed in the guidelines, what are the new research aspects to push this field forward? Because there's still people who don't agree that calcium scoring is important, and there's other people who think that we could use calcium scoring in new ways, and I count myself in that group. So for any of you out there interested in imaging and prevention, where those come together, hopefully I'll pique some interest in topics today. But let's start, like any good lecture, let's bring it back to the bedside. Let's start with the case. And what I always like to say when I present cases in these sorts of lectures in preventive cardiology is by design, these cases are very simple. These are patients you see every day, or these are family members that ask you about their own condition, or even other physician colleagues. But it's still, the decision-making can be complicated. So let's consider a 55-year-old non-smoking and non-diabetic man with good diet and exercise habits, but who has a family history of coronary disease. His father had an MI at a young age, so he's worried. You do an exam and his blood pressure is in the stage 1 hypertension zone. His HDL is pretty good, but his LDL is certainly higher than you'd like it to be, perhaps about 1 standard deviation higher than the population average. And of course, you start like the guidelines would have you do by calculating the pooled cohort equations. And he comes out as 6.4% 10-year risk. He's clearly what we refer to in the new guidelines as a borderline risk patient, right? He's neither low risk nor high risk. In fact, he's not even intermediate risk. He's in what we call the borderline risk zone, where certainly the decision-making and treatment decisions are uncertain. So I think we'd agree this is someone you see every day, and it's going to be the backdrop for what I talk about today. Does imaging help us understand what to do with this gentleman? Okay, and of course, we're going to talk about calcium scoring, as we've alluded to. You know, the great advantage of calcium scoring is it can be done on any modern multi-detector CT as long as you have cardiac gating software. So this is a test that is accessible to everyone. Now, the patient here is shown in a gown, but the patient could easily be in street clothes. In fact, you could do this right after your visit in the clinic. You could send them down to the scanner. They just need electrodes on their chest. And about 10, 15 minutes of room time and less than certainly 1 minute of acquisition time, really a second of acquisition time, and about 1 millisievert of radiation, you can do a calcium score. And as opposed to CT angiography, where you do it differently, depending on what scanner platform you have, or maybe your technologist or the heart rate might change your approach, the calcium score, you largely do it exactly the same way if you're here in New York or around the world. So it's a very reproducible and fast test by design so that it's applicable to our patients in the outpatient setting. And you get images, of course, that you all know look like this. They're unenhanced images of the heart. This is not a contrasted study. The things that are bright, that are highly attenuating of X-rays is calcium. And all the operator needs to do is to figure out that calcium is within the coronary arteries and not in the mitral annulus or the pericardium and circle that, and you get a calcium score. And of course, the idea is that this calcium score is indicative of your coronary atherosclerosis burden and your risk. So really, you go back to the days of John Rumberger when he was at the Mayo Clinic to really look at the fundamental understanding of the way the calcium score works, right? This is data from an autopsy study. This is amount of calcium on the x-axis, the total amount of plaque on the y-axis. And with just 38 patients, he was able to show the fundamental understanding of calcium scoring, which is that the more calcium you have in your coronary arteries, the more plaque you have. This is a test of plaque burden. That's the way we understand it in the modern era. And then we've gone on to show that plaque is quite heterogeneous in healthy populations. This is data from the multi-ethnic study of atherosclerosis, making the point that even young people can have advanced atherosclerosis. But importantly, patients above the age of 75 that would generally be considered to be high risk by any traditional scoring algorithm, about 20% of those have no detectable atherosclerosis whatsoever. So atherosclerosis is heterogeneous across age groups. Yet when you look at the event rates in a study like MESA, they're directly proportional to the burden of disease. Those young patients with advanced atherosclerosis have a similar event rate to other patients of different age groups who have a similar atherosclerosis burden. And likewise, the patients who've managed to live to an older age with a low atherosclerosis burden have a low event rate. So once again, we learned that in population-based studies, your event rate is proportional to your burden of disease, and the calcium score is a great test for the burden of disease. But we also understand the calcium score to be more than just that, because really what it is, it's a reflection of the lifetime exposure to risk determinants, which include poorly measured things like genetics, as well as the traditional risk factors averaged over time, as well as the vulnerability in an individual to those risk factors. In that sense, the calcium score can be thought of as a marker of biologic age. It's a measure of the kind of the vulnerability and the lifetime exposure to risk factors. And as such, it's actually a predictor of not just cardiovascular outcomes, but non-cardiovascular outcomes too. So in this study, you can see here, patients with higher calcium scores are more likely to suffer a first non-CBD chronic disease event as well. So patients with high calcium scores are more likely to develop cancer, or more likely to develop chronic kidney disease, more likely to be hospitalized with pneumonia and develop COPD, as well as suffer dementia. So this is really important as we understand the calcium score to be a signature of subclinical vascular damage that really extends beyond just our understanding of coronary plaque burden. And as such, you can use the calcium score for very important projections about a patient's lifetime risk. So here we're looking at the competing risks between dying of a cardiovascular disease in red or dying of cancer, which is the second leading cause of death in the United States, in blue. So if you know the calcium score, could you figure out what a patient is more likely to die of in their lifetime? And the answer is yes. So if you look here, if you're a 55-year-old patient and the score is 300, you're certainly much more likely, it seems, to die of cardiovascular disease than cancer in your lifetime. But if you're 70 years old and you have a score of 0, you're more likely to suffer from a non-cardiovascular disease mortality. And this is critically important as we understand what of our interventions are more likely to improve mortality in a patient and which of our interventions are less likely to have clinical benefit. So giving this broad picture of the calcium score, more than just a predictor of cardiovascular events, but you can use it as a projection of kind of the biologic age of the patient and what they're likely to succumb to. And as you may know, and we've alluded to, it's also important to note the calcium score when absent, when calcium is absent, is the strongest negative risk marker for developing cardiovascular disease. And having a calcium score of 0 is more strongly reassuring than the absence of a family history, than having a healthy lifestyle, or having a low CRP value, for example. And this is important. And this is consistent with what we call the imaging hypothesis of atherosclerosis, that due to the superior sensitivity of this test, imaging tests for subclinical atherosclerosis, like the calcium score, are excellent also for ruling out or downgrading risk estimates when calcium isn't present. So not only can this test find patients who are higher risk, it also can tell you who's lower risk, who has a lower sort of biologic age than you might have guessed. And this is important. the concept of the risk-enhancing factor is in the guidelines. And that's tests that when present, enhance your risk. And the implicit assumption there is when that test, you do that test to figure out who you should be treating more aggressively. And that's things like genetic tests or a C-reactive protein test, for example. But the calcium score is distinct from a risk-enhancing factor. It's a true risk stratifying tool. It can find patients not only that are higher risk than you thought, who need more aggressive therapy, but also patients who are less high risk than you thought, that you may be able to treat more conservatively. And this is important. It's not just a tool to find who to treat more aggressively. It's a tool for true risk stratification and also figuring out patients who seem to be protected against the risk of cardiovascular disease. So we've been arguing for a long time that you could use things like the calcium score to personalize decision-making in preventive cardiology and use tests like the calcium score to target subgroups of patients expected to derive the most and the least benefit from our interventions, like statins and aspirin we'll come back to. That focusing treatment on the subset of individuals with measurable atherosclerosis may be more appropriate allocation of our resources in primary prevention, rather than either a treat all approach or a treat based on age or another approach. So this is really, I think, the future of precision preventive cardiology. Once again, taking these broad population-based concepts and applying them to individuals in our clinic and saying, are you more or less likely to benefit from our interventions than the average? Okay, so this is all, you all know this so far with what I've told you, and this is in the guidelines. So in the 2018 cholesterol guidelines from the ACC and AHA, if you're between the ages of 40 and 75 and you don't have familial hypercholesterolemia, you start with a 10-year risk assessment, and particularly if you're in the borderline to intermediate risk group after considering risk-enhancing factors like a family history. If the decision about your risk and treatment is uncertain, do a calcium score. And in broad strokes, when the score is 0, you're lower risk. When the score is high, above 100, above the 75th percentile, you're at higher risk. So this is in the guidelines. And of course, our patient that I told you about at the outset is clearly in this orange borderline risk group where risk discussion and further risk stratification is important. And this is the way it's written in the guidelines, a class 2A recommendation. An intermediate risk or select borderline risk adults, if the decision about, for example, statins is uncertain, it is reasonable to use the calcium score in the decision to withhold, postpone, or initiate statin therapy. Once again, not just treat more aggressively when present, but also the options to be more conservative when the calcium score, for example, is 0. And I'd like to point out that there's data that suggests that treating according to the calcium score produces more benefit. This is the only randomized controlled trial of lipid-lowering therapy that had calcium scoring done at baseline. This is the St. Francis randomized control trial, a single center study of just 1,000 patients. What I'm showing here on the left is that patients at the bottom appeared to get a greater relative risk reduction from statins when the calcium score was higher, and most certainly a greater absolute risk reduction when the calcium score is higher, much more so than, for example, if you compare to CRP, for example. And in this study, which is using real-world data from the Walter Reed clinical cohort, Todd Valines and others matched people who got a statin versus those who didn't get a statin, and then looked at their baseline calcium score and looked at the benefit accrued over time. And you can see here that when the calcium score was 0, the lines were superimposed. There didn't appear to be much benefit in these lower risk patients over time with a statin, but as the calcium score went up, and certainly when it's above 100, a large relative and absolute risk reduction when you treat with a anti-atherosclerotic therapy against the background of established plaque. So emerging evidence that using the calcium score produces more, at least absolute benefit, if not relative benefit in the real world. Okay, so once again, so all of this that I've told you so far, I think you've probably heard before. It's in the guidelines, and hopefully many of us are already practicing this way. So what's new? The rest of the talk will be about what's new, and particularly what research topics still exist in the field of calcium scoring, because certainly the entirety of the story has not yet been told. So I want to focus quite a bit on in this talk is how we can use calcium scoring to guide decision-making about other preventative therapies beyond statins. Because I think this this story about calcium score and statin decision making is sort of old and tired, in my opinion. We've been debating about this for 2 decades now. I think most of us are comfortable using it in this setting now. But what about the true value of calcium scoring, which is actually to guide the entirety of the decisions that we make in primary prevention? And this is really the paradigm, I think, that's emerging, which all of us sort of intuitively know, but we need to codify, I think, in the guidelines, which is that risk really is along a continuum, right? And instead of being primary prevention up until the day before you suffer your heart attack and then you become secondary prevention, we need to recognize that there's a group of patients who need an approach consistent with primary prevention. We certainly have an approach, a group of patients that need secondary prevention strategies. We also have a large group of patients with advanced subclinical atherosclerosis whose risk is intermediate or sometimes just as high as secondary prevention, who need their own dedicated approach that's more aggressive than the traditional primary prevention approach. I think we're going to see clinical trials focused on this population in the future. I think we're going to see guidelines focused on this group in the future. And we're going to start using the terminology differently. So we're not saying a primary prevention patient. This is a patient with advanced subclinical atherosclerosis that may need to be treated in a particular way. So let's talk about some of the data on this. So let's talk about aspirin, because of course aspirin is extremely controversial in primary prevention. There's a class 2B recommendation or a class C recommendation from the USPSTF, lukewarm for aspirin primary prevention, certainly across the entirety of the spectrum of risk. But can you use the calcium score to find who's going to be more likely to get a benefit from an aspirin? So let me explain this plot to you here. What I'm showing you is in blue, all patients, or in orange, patients with calcium score of 0, or in shades up to green, patients with higher calcium scores. What the bars here represent is the number needed to treat. The number needed to treat for 5 years with an aspirin to prevent 1 cardiovascular event. And what the red line is the number needed to harm. The number you needed to treat to cause 1 major bleeding episode with aspirin, because we know that aspirin is risky. And what you see here in blue is that if you just use the pooled cohort equations, you can't find a group of patients who reliably benefits from aspirin, because the number needed to treat, as it improves, the number needed to harm also gets lower. And this is why the guidelines are so lukewarm on aspirin, because in many patients, the benefits are counterbalanced with the risk. But the advantage of the calcium score is it can find patients who are higher risk than you would have thought, who don't necessarily have higher risk of bleeding. So you can see here in green, if you're a low risk patient or intermediate risk patient, or even a high risk patient, when the calcium score is high, the number needed to treat that we project becomes much lower than the number needed to harm, particularly in younger patients with advanced subclinical atherosclerosis. So this is why the Lipid Association, National Lipid Association guidelines, as well as the Endocrine Society and the SCCT have commented on the use of aspirin only in those patients with a calcium score greater than 100. And you can see in orange, if you're treating your patients who have calcium scores of 0 with an aspirin, you're much more likely to cause harm than you are benefit. And I think that's an area where we could start being more selective right now in those patients who might come to us taking an aspirin without a clear indication. Okay, that's aspirin. What about blood pressure? I'm going to show data from the calcium consortium here. But this is driven by the idea that in the SPRINT trial, we know that high-risk patients receive a benefit from intensive blood pressure control, right? If you're randomized to a blood pressure control more like 120 versus more like 130, there's a cardiovascular outcome benefit with tight blood pressure control. So we asked the question, well, in primary prevention, what calcium scores will give you the risk equivalent to someone who would have been enrolled in the SPRINT trial? And that's what's shown here. This curve, a linear relationship with the relationship of the calcium score and CVD event rates, in this case, mortality rates. In this study, a calcium score of about 250 gave you the risk equivalent of that of someone enrolled in the SPRINT trial. And we suppose then that the patients who have just as high as risk as those patients in SPRINT probably will benefit from tight blood pressure control. So I think this is starting to build the case that maybe we could even use the calcium score to decide about blood pressure goals in patients in our primary prevention clinics. Okay, talk about this risk continuum concept and how does this apply lipid lowering therapy? Well, I just want to introduce this concept. The patients with very high calcium scores, so-called extensive calcium scores, can sometimes have risk that's equivalent to that of a secondary prevention patient. So these patients are more likely to have 4-vessel calcium, including left main calcification. They're more likely to have extra coronary calcification at multiple sites, and they have high mortality rates. And if you look here at the Cbd mortality rate of patients in MESA who have a calcium score greater than 1,000, actually this is from the Calcium Consortium, but score greater than 1,000, it was equivalent to that of the patients in the placebo group of the Fourier trial, which is a trial of PCSK9 inhibitors in stable secondary prevention. So it's starting to raise this question again. These patients with very high calcium scores in our primary prevention clinics, are they just as high as risk of patients in secondary prevention clinical trials? We looked at also this in MESA, this is MESA data here, and found a similar result. If your score is about 800 or 900, you have the risk equivalent to the average patient enrolled in the Fourier trial. Even further down on the left, if your score is between 300 or 500 or so, you had a risk equivalent of the lower risk subgroups that were enrolled in Fourier. That included the patients who had only one prior index myocardial infarction, who had a revascularization but didn't have residual multivessel disease after their index event. So this is raising this question again of the overlap between patients in secondary prevention and high risk primary prevention. This is data on the right showing kind of a more detailed analysis of this data. This is published just recently. You can look in the right, showing what calcium score exactly equates to particular risk groups within the Fourier trial, whether you have diabetes or not, for example. And these scores are we see routinely in clinical practice, scores of 300 to 600 or so. These are giving you risk equivalent to certain lower risk subgroups in secondary prevention clinical trials. So it really raises the question, should we be reserving our most aggressive lipid lowering therapies just for those patients in secondary prevention? Or should we be attacking advanced subclinical atherosclerosis with a similar intensity that we do in our secondary prevention guidelines? Okay, what about diabetes and cardiometabolic disease, right? We have a lot of innovation in cardiometabolic therapies that reduce cardiovascular outcomes. How are we deciding whom should be getting these drugs? Well, I want to point to the ESC guidelines here on the treatment algorithm of patients with diabetes and ASCVD or at high or very high risk of ASCVD who are drug naive. I mean, these are patients we see in our cardiology clinics, right? Where we see them in the hospital with a new myocardial infarction, we diagnose them with diabetes, and we want to be involved in that decision on what drugs we give them for their diabetes to try to reduce their cardiovascular risk. Well, the ESC guidelines say if you're a high-risk patient, the first choice should be an SGLT2 inhibitor or a GLP-1 receptor agonist. And only if you're not high risk should you go on the conventional pathway of metformin and other oral hypoglycemics. Well, the question is, can the calcium score find patients who are more likely than average to get a net benefit or to get value out of the use of these medications? And of course, the answer seems to be yes. And I'll point out that in the ESC guidelines, there's a 2B recommendation for the calcium score in a non-high-risk diabetic. It says the calcium score can be considered a risk modifier in the risk assessment of otherwise moderate risk diabetics to put them in the group where class 1 recommendation for an SGLT2 inhibitor or GLP-1 receptor agonist. So we're routinely imaging our patients that are coming to our cardiometabolic clinic with obesity and diabetes, that we can prioritize the use of modern risk-reducing therapies in the right patients. And we can be more conservative with less expensive therapies in patients who are not at high risk. So what I'm trying to paint the case here is that we can use the calcium score for more than just the simple kind of generic decision of statin or no statin. So let's come back to our case. 55-year-old patient, non-diabetic, non-smoking, good exercise habits, has a family history, stage 1 hypertension and LDL above. Goal, we said he was a borderline risk patient. Now let's say we do a calcium score on him. This was a patient for my clinic, calcium score, and it came back elevated at 325. That puts the person at the 95th percentile. So what I want to ask that you listening into this lecture, either in New York or online, so how would you treat this patient? So would you treat this patient any differently based on the calcium score result? I know that some people out there would say, no, I wouldn't do anything differently based on the calcium score, but I would argue that you should. So how would you treat this patient? Would you use lifestyle therapy only? Well, if you didn't have the calcium score, that would have been a reasonable option for this patient with just borderline risk. But I argue it's under treatment of a patient with advanced subclinical atherosclerosis. What about a moderate intensity statin? A reasonable approach, right? The guidelines say there's a moderate level of evidence for a moderate intensity statin in borderline risk. That's a reasonable guideline-based approach, but I would argue it's an under treatment of this individual. What about high intensity statin and aspirin? That's sounding better. I think it's certainly more aggressive. I think it's consistent with the data I showed you about an aspirin. But I think you could even go further. In my clinic, I would say this patient in primary prevention, but who has advanced subclinical atherosclerosis, can get the most intensive lifestyle interventions I have, including potentially a visit with my nurse practitioner to talk about lifestyle, a high intensity statin and an aspirin. But I'm also very likely to try to attack that stage 1 hypertension with a low dose antihypertensive. And I'm also very likely in this patient with an LDL of 145, who's probably not going to achieve a goal of less than 70, even with the high intensity statin, to add on, for example, ezetimibe to get to a lower LDL goal. So what I'm trying to point out here is that the calcium score can be used to drive any of these decisions here on the slide. Anything from a more conservative lifestyle-based approach to a multi-drug approach based on the burden of subclinical disease in the patient. And I think the future of calcium-based recommendations are going to look something more like this, right? Multiple things, not just a statin, multiple things across the top here: lifestyle, statin and statin intensity, non-statin lipid-lowering add-on therapy, aspirin, blood pressure goals, or what I called here secondary prevention meds that we usually reserve for those patients in secondary prevention, and pointing out how the calcium score can be used to drive some of these decisions, with particular focus on these patients that are above the 90th percentile or above 300, where we're going to be more aggressive than our primary prevention guidelines would have us be. And focusing on these patients, particularly those scores of 1,000, these referrals I get, I treat them just aggressively as secondary prevention. So I think, once again, there's still lots of work to be done on thinking about how the calcium score can drive a wide array of decisions in our practice. And if one thinks about the calcium score just as a statin decision maker, I think the field seems quite established, but there's still a lot more work to do and a lot more interest in doing clinical trials, once again, in this space. I'll come back to that later. Okay, so what else is new? What about calcium score in those that are already taking a statin? Because the question then comes up, well, if you're going to be making these other decisions based on the calcium score, what about if they're already on a statin? I heard that you couldn't use the calcium score if you're already taking a statin. Well, it is true that statins cause a shift in your plaque types, right? You get a little bit of a regression in plaque and a shift from non-calcified plaque towards calcified plaque. This is CT angiography data from the Paradigm study. So it's true that when you treat with a statin, that your density of calcium goes up and your calcium score will go up a little bit. But if you actually look in detail, does the calcium score still predict risk in patients on statins compared to the patients not on statins? The answer is yes, it does, with nearly the same magnitude of effect. AUC, the area under the curve for those patients on statins, is similar to those patients not on statins. So while the calcium score can go up a little bit, calcium score still retains its predictive value in patients on statins. So I think this is important. This also points out why patients who come to you on a low intensity statin might still benefit from a calcium score to drive other parts of the decision making. Why patients who come to you with statin intolerance might benefit from a calcium score despite their prior statin exposure, et cetera. So I think another thing that we need to be thinking about is potentially using the calcium score also in patients who've been exposed to statins and whom there's further decisions to make. Okay, what about calcium scoring in the young? This is an important topic that I want to cover here, because it turns out that calcium is more prevalent than we once thought, even at young ages. So here, this is data from the Calcium Consortium. Even patients in the 30 to 40 or the 40 to 50-year-old age group have a non-negligible prevalence of calcification. Even in the age 30 to 39 group, about 20% of patients had some calcification in this study, and a couple percent had already advanced atherosclerosis. And if you look at the event rates on the right, even in these young patients over a 10-year follow-up, their mortality rates, particularly their Cbd mortality rates, are much higher. So calcium scoring is prognostic and potentially useful even in younger patients. What about this unique group? looked at the patients just between the ages of 20 and 30 from the calcium consortium. Now, granted, these patients were enriched in risk factors. We said, what's the prevalence of calcium even in these very young patients? Well, of course, it went up with risk factors. But if you had multiple risk factors, 2 risk factors or 3 risk factors, the prevalence of calcium is already 15 or up to 35%, even in these young individuals. But the catch is the mean calcium score in these patients who had calcium was just 4, right? This reminds us that calcium starts as the smallest little pixels of calcification that can be detected on CT scan long before they grow into the calcium scores we're used to seeing at older ages. So we need to be reframing our thinking at young ages to detecting the earliest manifestations of atherosclerosis. And this is a reminder of the difference between the total score, the calcium score, and the percentile score. So many people don't realize, I think, that the Agatston score is actually on an exponential scale. And that we remain at the calcium score of 0, hopefully for half of our life or longer. Then it takes actually 12 to 15 years to progress from a calcium score of 1 on the average to a score of 100. But then very little time to go from a score of 500 to 800, right? So this is on an exponential scale. And I think most people don't think about it in that way, but let's think of this. Let's look at a male patient, the 90th percentile for their calcium score. This is where from data from MESA would suggest that patient would reside. And it turns out that patients tend to progress with their calcium score at their percentile curve in the absence of any intervention. So the patient that comes to you with a score of 110 at age 50 or a patient of 450 at age 60 is actually quite the same patient, just shifted along the natural history by 10 years. And hence, if you go back in time, this patient would be estimated to have a score of about 10 at age 40. So this person would have a detectable coronary atherosclerosis at age 40, decades before this patient manifested later as an adult, older age adult patient with advanced atherosclerosis. And this is important because if you look at the relationship of the calcium score with CVD death rates here, it's logarithmic. This reflects the inverse of the exponential relationship that we know with the Agatston score. So it turns out that most risk stratification occurs at low calcium scores. Between the scores of 0 and a couple hundred is where most of the risk stratification with the calcium score is done. And I think as we know clinically, once your score is 600 or 800 or 1,000 or 1,200 or 1,500, you don't gain that much more in terms of risk prediction. The person's already high risk. So really we should be spending more of our effort trying to detect, I think, patients at the earlier manifestations of the calcium score. So we did this study looking at the optimal age to initiate calcium scoring based on risk factor burden. And this looks at the probability of having calcium in men or women at certain ages based on risk factor profile. And we also looked at the so-called offset period, the amount of years earlier you get calcium if you have a particular risk factor. And then also the age at which you should initiate calcium scoring, at which point there's a 25% chance that you have calcium. So it's confusing, but I'll go through it here. So let's say a patient with a family history and hyperlipidemia, like the patient in our vignette. If that person's a man, well, there's a 25% chance that person will have calcium at the age of 35. If they're a woman, it would have been 48. And that's 8.5 years earlier than if they had no risk factors. So this is a study that I think can help us identify when we should be thinking about calcium scoring in our patients. And if a patient has no risk factors, a man at the age of 42, a woman at the age of 58 has about a 25% chance of having calcium. So this helps inform when we should be thinking about calcium scoring and the expected yield. And I think this is valuable. For the first time ever, just recently, we have published the first percentile calculator for calcium scores between the ages of 30 and 45. It used to be, if you're a reader of calcium scores, you'd go to the MESA website and calculate the percentile for your patients, but there was no option for calculating the percentile before the ages of 45 because MESA didn't have patients in that range. So now if you go to cactools.com, the link here is shown at the bottom, you can go in and calculate the percentile for your younger patient that might have had a calcium score. So you read a calcium score on a 36-year-old, maybe this person had a family history that was strong, they had a score of 8, and you'll quickly see that even that low calcium score puts this patient at the 91st percentile, helping us to understand that even these low scores in young people are very abnormal and prognostic. Okay, I'll just mention a research project that we have going on. So what we're doing is we're actually building tools to be able to predict the age at which someone who has a positive calcium score would have been first detectable theoretically with the calcium score test. And this is in data from MESA. I won't go in great detail, but it turns out this is the distribution of when someone first had a detectable calcium score in MESA. And you can see this in healthy patients recruited from the community, certainly a non-negligible amount would have had detectable calcium well before the age of 40 in MESA. And it turns out if you look at that value, and you look at that value when someone first detected a detectable calcium score and how long that was before their cardiovascular event, the mean latency between someone having a first detectable calcium score and having a cardiovascular event in MESA was 24 years. So generally in MESA, on the average, the time in between someone would have been first detectable with the calcium score and their cardiovascular event was 24 years. So I think this dispels a little bit of this conversation that you hear sometimes, that the calcium score detects people too late, or that nothing can be done once you have calcification because the disease is already advanced. I think if you detect it earlier, we have lots of time to change that natural history. Okay, well, we talk a lot about the calcium score of 0. A question that comes up all the time is, well, what is the warranty period of a calcium score of 0? In other words, when should the test be repeated? Because you don't need to repeat it every year. But this is data on the warranty period from MESA. This is data at the top let's look at for intermediate risk patients, let's say. And this is the number of years you need to wait before you have a certain testing yield for a repeat calcium score. So let's look here in the middle. Let's look at having a 20% chance of having calcium on a repeat test, a number needed to screen of 5. Let's say you're an intermediate risk patient. About 3 or 4 years. In about 3 or 4 years, about 1 in 5 patients will convert it to a positive calcium score. Or if you want to wait till 1 in 4 people had converted, about 4 to 5 years. And you can see the different data for low, intermediate, and high risk patients. And this is why in the Endocrine Society guidelines and the National Lipid Association guidelines, it says repeat the calcium score in 5 to 7 years for low risk patients, 3 to 5 years in intermediate risk patients, or 3 years if you have a high risk patient. And this is prognostic. So if you look at the bottom here, we know that patients have a very low event rate in the coming 5 years after a calcium score of 0. If you rescan them at that point, in MESA, 28% of patients would have converted to a positive score, 72 patients remained with a score of 0. And then it looked at the ensuing 10 years. Patients who had a score of 0 and then score of 0 again had only a 1.8% event rate over the coming 10 years. But patients who converted to a non-zero calcium score had a middling event rate of 5.7% over the next 10 years. In other words, you can differentiate patients quite a bit with a repeat calcium score. So I think the future is thinking about tracking patients over time to look for that development of the earliest manifestations of atherosclerosis and thinking about risk appropriately. Okay, and the final couple topics I'll go through quickly. What about new tools for commuting calcium-based risk? I think hopefully some of you have heard of the MESA risk score. This is the first tool where you can plug the calcium score in with traditional risk factors and get a 10-year risk. At the bottom here, you can see an example. On the left is a 60-year-old patient with a score of 0 and multiple risk factors. On the right, a 60-year-old patient with no risk factors and a calcium score that's elevated. You can see here the second sentence gives you the risk of that patient if you ignored the calcium score, and the first sentence, the risk if you included the calcium score. So this person on the left went from a 15% risk to a 4% risk based on the result. This person on the right went from a 3% risk to an 8% risk based on their elevated calcium score. So this is a great tool for figuring out how to incorporate the calcium score into practice. So let's go back to our case then. So we had this patient who we said was borderline risk, and we did a calcium score. So now we can say this person would have had a 2.8% risk in the coming 10 years if their score came back 0. And we'd be hard pressed to say that we're going to lower that risk a lot further in the next 10 years. But since it came back elevated, the coronary risk, just the coronary risk for this patient in the next 10 years is 13%. Now it turns out that some patients say, well, I don't know what that means. 13%, isn't that still pretty low? So now we have a new tool that will be up on the website soon about how to translate that risk into a so-called coronary age, to translate that into an age at which a healthy patient will have the same risk as that patient. So let's consider this 55-year-old patient here We know that because the person's calcium score of 0, their risk is lower. So while their actual age was 55, we can say that their coronary age, now that we've incorporated the calcium score 0, would be 42. So sometimes patients understand this better, that we say you actually have the risk of a healthy 42-year-old, even though you're 55, because your score came back 0. But in contrast, right, same patient has a score of 300. Now we say instead of having an actual, instead of your age of 55, you actually have the risk of a healthy 77-year-old. You have the arteries of a 77-year-old because your score is 300. You have the risk of a 77-year-old. So sometimes patients understand this better. And this tool will be up on the website soon as a potential way of helping communicate with your patients. We did a scan and it turns out your arteries look older than you are. And sometimes patients understand this more. Okay, another research topic in calcium scoring that shouldn't be ignored is the idea of at least visually interpreting the calcium score on non-gated chest CTs. So CTs that are done for another indication, let's say for COVID or for lung cancer screening, can we still glean information from that? Well, it turns out there is a class 1 recommendation from the SCCT and the STR to at least visually interpret calcium score on all chest CTs. And there's actually a tool for doing this called the Calcium Data and Reporting System, so-called CAC-DRS. And it's pretty simple. It takes conventional calcium score groups, 0, 1 to 100, 100 to 300, greater than 300, and maps on top of that none, mild, moderate, or severe calcium by visual estimation. So in other words, a CAC-DRS score of 0 is equivalent to someone with a calcium score of 0, CAC-DRS score of 3, where someone has moderate to severely notable calcium on a score, as a same CAC-DRS as a calcium score greater than 300. And even you can even go further this with the CAC-DRS system and say, well, how many vessels are afflicted with calcium? You can see here, if you say, well, I just looked at the calcium score and there's moderate calcification in 3 vessels, that would be a CAC-DRS score of V2, visual 2, and 3 vessels. So this is an easy way of communicating calcium on a non-gated chest CT and say, well, I saw moderate calcification in 3 vessels. And it turns out that is just as prognostic as an official calcium score. So this is data from the Calcium Consortium, looking at different CAC-DRS groups here on the x-axis, ranging from no calcium to calcium that's more severe and in more vessels. And you can see a nice gradation in risk. The more calcium you have and the more vessels it's in, the higher your risk of cardiovascular disease. So I think this is part of the future too, is leveraging from our electronic medical record system incidental detection of calcium on a variety of chest CTs. When you're on the consult service, looking at old chest CTs to try to get a better sense of risk. Okay, you might have heard new data on calcium scoring in chest pain or even new guidelines. And it's based on data like this. So we know that patients who come to the emergency room are actually lower risk than we think, right? If you come to the emergency room with chest pain and your EKG is negative and your initial set of enzymes is negative, you're a relatively low risk patient. And actually 56% of those patients have a calcium score of 0. And only 1 in 20 of those patients have any plaque detectable on a CT angiogram. Less than 1 in 100 of those have obstructive CAD, and less than 1 in 200 of those in the coming years need a revascularization. So in other words, the diagnostic accuracy of the calcium score in acute chest pain is pretty good. It has about a 99.3% negative predictive value for having an important cardiovascular disease outcome. So that's why new chest pain guidelines say if you've got a low-risk patient, once again, this is a low-risk patient, which I think would include patients with, let's say, an acute care center with negative enzymes, negative EKG, or more importantly, your outpatients who come to you with kind of atypical chest pain symptoms. If you have a patient who's low risk with chest pain, there's a class 2A recommendation to consider the calcium score as a first-line test for excluding calcified plaque and identifying patients who actually have a low likelihood of having obstructive CAD, similar to an exercise test. And I think this is great. I think there's patients out there who benefit from just a simple calcium score to help stratify their risk of having obstructive CAD when they have non-typical chest pain symptoms. And of course, if the calcium score is elevated, then we could move on to either a CT angiogram or functional testing. But most patients, many patients you'll find will have calcium scores that are 0 in this scenario. Okay, so what's new with calcium in clinical trials? So this is important because one of the criticisms you always see about calcium scoring was, well, there's no definitive clinical trial. There's no clinical trial that says that calcium scoring works. Now, this is really hard to do because it's a risk test. It's a prognostic test. And it's very hard to prove that prognostic tests improve outcomes without linking them to an intervention, right? So the trial designs are complicated because you need to have a prognostic test that's linked to an intervention, and you need to have that intervention not be applied to the control group, and you have moving targets over time of what standard of care is. So the NHLBI convened a panel recently to talk about what are the ways that we could do a clinical trial with calcium scoring to try to get a higher level of evidence. And here's some of the ways that have been proposed. There could be opportunistic use of calcium scoring on non-gated chest CTs. There could be using calcium scoring at younger ages, which I've talked about. Maybe we could be using calcium scoring at older ages to find out who won't benefit from preventive therapy at older ages. Lots of potential strategies. But I will say there's a couple trials ongoing right now. And one is the CoreCal study out of Intermountain Healthcare System, which is using the calcium score to try to drive further decision-making and improve outcomes. And initial data from CoreCal has shown that they are seeing that the calcium score is driving meaningful changes in clinical decision-making. We'll have to see if that translates into cardiovascular benefit. And we have funding to perform a sub-study of the preventable trial to do calcium scoring in half of the patients in the preventable trial to see if older patients above the age of 75 randomized to atorvastatin get benefit in proportional to their calcium score. So we're having a couple ongoing. There's a trial in Europe right now called Rubinska that's similar to CoreCal. Several trials ongoing right now to hopefully provide a higher level of evidence that the calcium score helps drive decision-making and improves outcome in clinical practice. And I think the future is, with new therapeutics, is calcium score enrichment of the population. Instead of, let's say, a primary prevention study of taking all comers in primary prevention and giving them a new therapeutic, can we be doing much smarter clinical trials by enriching the population just in those patients with advanced subclinical atherosclerosis? And if you just do a trial in patients with advanced subclinical atherosclerosis, you're going to have much more likely to be positive. You're going to have a much shorter trial, and you're going to have a cheaper and smaller trial, and also more clinically relevant because you're much more likely to use that therapeutic, of course, in patients who are higher risk. So I'd like to see more trials enrolling patients with advanced subclinical atherosclerosis as a new indication for, let's say, lipid lowering therapies or new anti-inflammatory therapies, et cetera. Okay. I'm going to go through this really quickly because I know we're short on time. Just one of my personal research interests is, what about new calcium scores? Do we actually need a new calcium score? Is the calcium score that we have sufficient? So if you're interested in this topic, I've got a review paper on this that you can read. But I think we all know, who are imagers, I think this is an imaging audience, that these two patients aren't the same, right? They have a calcium score that's 200. But the person on the left has focal dense calcification in just one vessel. And the person has low attenuation, diffuse plaque across all the epicardial coronary arteries. And you can define a lot of ways that these patients are different. They have different density of their calcium, different number of vessels involved, different pattern of involvement, different number of lesions, and different lesion size. There's lots of ways to think about separating these patients out. And we know from multiple studies now, this patient on the right is higher risk than this person on the left. The person on the right's got much more plaque, much more diffusely. Because we know that your risk goes up with how much area of calcium you have, but actually goes down with the density of calcium. We know that the more diffuse your calcium is distributed, the higher risk you are, the more concentrated it is, the less high risk you are. And further than that, we also know the more extra coronary sites you have involved with calcium, the higher risk you are, right? So if you've got calcium in your aorta, your mitral annulus, your aortic valve, you're higher risk than if you had calcium in just the coronaries. So can we be using more data off the chest CT to improve risk prediction? And if you go through the paper, you'll see some of the things that I suggested about what the features of an ideal calcium score would be, right? It has to be simple. It has to be easy to calculate from available imaging data. It has to be still low radiation, et cetera. It has to be on a scale that we're all familiar with using. I went through the pros and cons of having a new calcium score. Do we really need one? Or is this really just noise? Is it really going to improve outcomes? And you can read about it in the paper. And I talk quite a bit about kind of what's the pros and cons of a new calcium score in terms of the added complexity versus the gains in risk prediction. I think a smart new calcium score that can be assessed just as fast as our existing calcium score, perhaps with the help of artificial intelligence, was even going to make risk prediction better. All right, so let me conclude, so we have time for a few questions here, by saying that the calcium score is now guideline endorsed and ready for prime time. But there's still lots of important research questions. Hopefully, if you're out there and you don't think about calcium scoring a lot, you just thought of it as a tool to decide if you should be on a statin or not, you've come out of this thinking, well, it's a little bit more interesting than that. Because calcium scoring is not just for statins, it's for guiding all of preventive therapy. In fact, it's for defining a distinct group of patients called advanced subclinical atherosclerosis. And there's emerging research topics. Can we further risk stratify patients who are already taking a statin? Can we use the calcium scoring in select younger patients? When do we repeat the calcium score, and does that add value? And what about interpreting calcium off non-gated chest CTs that were done for other reasons? What about using the calcium score in low-risk chest pain? Can that improve the efficiency of our care? And then randomized controlled trials. How can we be innovative to design randomized controlled trials that are ethical in this era where the calcium score is recommended in the guidelines, but still provide higher level of evidence for calcium scoring in practice? And then this notion of, can we improve the calcium score? The calcium score was made in 1990. Can we improve upon it? I think we probably can. So I'll say thank you for this opportunity to speak, and hopefully I've covered a lot of topics that whet everyone's appetite for more research, and I'll take some questions.
Thank you so much, Dr. Blacka. That was outstanding. And when we think that we know everything about calcium score, then we see lectures like yours, and we realize that there's so much more to do and so much exciting research about it. So please put your questions in the QA, and we'll go through them. I really like the idea of this new calcium scoring and the use of AI. I mean, we still circle the areas to detect the calcium. How far are we from using AI for that?
I mean, I think we know a lot of the parameters that would improve calcium scoring now, but I think it sort of has to be a wholesale change, right? I think there's little plugins to make the calcium score a little better by changing the density, weighting factor, et cetera, probably aren't going to make a big difference. But I think we need a comprehensive calcium score that includes multiple aspects of improved scoring, including the potential for lowering the density threshold for detection of calcification, potentially even using thin slice reconstructions. So there's lots of things to think about here. And I think the answer will be, once we have a single new calcium score that shows significant improvement over what we have, we might propose like a wholesale change. But I'm not as big a fan of kind of, one small change. So I think we're close to knowing some of the parameters, but I think we're a long way from showing that a new calcium score is going to improve risk prediction as much. Because as you know, we're still trying to convince a lot of people that there's value in the existing calcium score. But we know that there's a lot more in there. So I think we're a little ways away, but you can see it on the horizon.
That's great. So we have a question from Michael Pato, one of our fellows that is doing also research in calcium scoring. He says, thank you for the amazing talk on this very important topic. 2 questions. In asymptomatic patients, is there a CAC score or CAC distribution that you then follow up with other testing? Like, should you do downstream testing is the question 1. And then I'll read you a second one. And how do you use the incidentally discovered CAC on non-gated chest CT?
Yeah, so it's great, because the first question is such an important one, because it really is one of the things that's held back calcium scoring from being higher in the guidance. If you actually talk to the people who are sort of calcium naysayers, they say this is one of their biggest concerns, that calcium scoring will lead to inappropriate use of downstream testing and ultimately revascularization in patients who didn't need it. And that's one of my biggest concerns too. So in the new National Lipid Association guidelines, it says there's a class 3 recommendation. Don't do it. Don't do follow-up testing if your patient is truly asymptomatic. And I think that we can all agree on that, right? In the era of Courage and the ischemia trial, if your patient's completely asymptomatic, particularly if they're running a couple miles a day and they're free of symptoms, they have a high calcium score, just manage them medically. You don't want to open that box with a functional test. Now, where we do need more research is, what about the patients who the symptoms aren't as clear, right? Patients who don't exercise, they don't do much, they get a little short of breath, when they walk a quarter mile, they don't have chest pain. I think we need to know a lot more about those patients. And I think it's still reasonable as a class 2B recommendation in the nuclear guidelines, the diabetes guidelines, to do a stress test in those patients who scores about 400 who have equivocal symptoms. I think that's reasonable, but I don't think we're guided by as much evidence as we should be. So this is a great research topic if someone could try to really eke out where there's value in testing, because we know that in the community, I don't think a very thoughtful approach is taken always to this. And then there's inappropriate use of downstream tests, and you get the naysayers, which happens. So great research topic. That's the way I practice. I medically manage and assess symptoms, but what I do is I dive in deeper on symptoms if the score is elevated, right? That's when you don't just say, well, do you have chest pain? Yes or no. What's your exercise tolerance? Is that changing? Do you get short of breath with normal activity? And you're going to find patients with 3 vessel disease clearly hidden in there. We all do. So that's a great question. And then these non-gated studies, what's written in the the National Lipid Association guidelines is that if you look at a non-gated study and you've got a ton of calcium, kind of like the CAC-DRS3 V3 category, I mean, you don't need to do a formal calcium score. You sort of know the patient's got advanced calcification. It says the patient's got mild or moderate calcification. It is still reasonable to do a formal calcium score to know where they stand. But I think the future will be that we'll become more confident in acting even on these qualitative assessments of calcium on non-gated studies. So that's the way I practice right now. I feel comfortable in a patient who I've seen a lot of calcium on a chest CT who's referred to me maybe for that reason to not even do a calcium score. I'll just record in the chart severe coronary calcification and treat as such. So I think that's the future, but it's always reasonable to do a formal calcium score if you get one of these referrals, if you're uncertain or you don't have the images available to you.
Okay, thank you very much. And from Aldo Scanone, one of our imaging cardiologists, he says regarding that, when you decide to treat medically, what LDL goals do you use based on the CAC score?
Yeah, I think that's a great question. The way I do it is pretty simple. I sort of divide my patients into primary, secondary, and advanced subclinical athero. If they're primary prevention, you sort of follow the guidelines, put them on a statin of the right intensity without a specific LDL goal. Just try to get the LDL down, 30 to 50%, or for high intensity statin, 50%. The secondary prevention guidelines say get an LDL less than 70. The Europeans would say less than 55, or maybe our next set of guidelines less than 55 if your patient's very high risk. And I think for the advanced subclinical atherosclerosis population, I just treat them like the secondary prevention guidelines. I will try to get to those LDL goals of less than 70 or particularly less than 55 in the highest risk patients. And that's why I think that I don't want to consider these patients under the primary prevention rubric always, or I think you're going to undertreat them. So that's the 70, 55, whatever you do in secondary prevention, I recommend that you do in your patients with high calcium scores.
And actually, some of the insurance companies cover PCSK9 inhibitors if your CAC is about 400, and which is surprising because they usually don't go that route.
I think that's a smart. I try to make that case, and I'm successful sometimes in saying this patient has coronary disease and they need a PCSK9 inhibitor, particularly if they're in that borderline heterozygous FH population. So I think that's what we need is more research to convince everyone of a systematic approach to this, that we don't have to say, well, maybe they'll approve, maybe they won't, but a more concrete recommendation there.
We have a question from our fellows that are watching all together. They say, we know that CAC is a late marker of atherosclerosis. Is there a substantial amount of patients? The question is, what patients have a CAC of 0 but significant CAD? And is there a group where CCTA should be done instead of CAC?
Well, it's great question, great timing for that question, because we finally have data on this question. So I'm going to refer to the patients who are just healthy from the community. So there's data from the the Miami Heart Study, and then there's data from the Scapis trial, which is in Sweden. One's 30,000 patients, one about 3,000 patients of asymptomatic patients who got calcium scores and CTA. So you can go out there and read about this. And there's data from other studies too. But it turns out it's very unlikely that you're going to have advanced atherosclerosis, right, if your calcium score is 0. You're going to find maybe 1 in 10 patients who have plaque on CTA that you didn't detect on the calcium score, but not usually advanced disease. Now that's talking about primary prevention. So I think primary prevention, the answer is still the calcium score. Now it's a little different if you're talking about symptomatic patients in the emergency room, where we prefer, of course, CT angiography, because it becomes enriched in these patients with obstructive disease. despite low calcium scores. So I think I'll just leave you to maybe look at those two great studies and where you can really discern where you think the benefit is. At least when I read them, I don't see a big benefit of CTA over calcium score in asymptomatic patients on the average. Maybe we could have a conversation about familial hypercholesterolemia, for example, but not on average.
And then, so Dr. Scarone asked another question related to that. I mean, we're having an issue with calcium score being covered by insurance, and it's this creates disparities in care because the patients you see in LA are not the same that you see in the Bronx. And what are we in advocacy for this, for change?
Yeah, that's a great question. I'm not big on the advocacy side. It's not something I put a lot of time into, but I know a lot of folks who have. And Ron Blankstein, who's the SCCT president, has put a lot of effort into this, as well as Matt Butoff over time, and scored a lot of gains. A lot more insurers, private insurers will cover the calcium score now. And there's high-level conversations with Medicare about reimbursement for calcium scoring that I hear are favorable. So I think this is coming. I think there is a lot of advocacy, particularly from the Society of Cardiovascular CT, and hopefully from all of us in the imaging community for reimbursement. Now, one of the tricks, of course, is this is such a cheap test to begin with that it's harder to have this conversation about coverage because, for example, at Hopkins, we offer it for $75 as it is, and there'll be a tendency to charge insurers more than that, to try to recoup. So anyway, so it's a complicated question, but on the SCCT website, there's some updates on the advocacy that you could look at.
That's great. And I think just to finish maybe one last question, and I'll combine them. So the question is, in these patients, you may end up putting in many medications, for example, in the patient in your example. Do patients usually, do you find that they are reluctant for that, or the calcium score helps you for that? I know there's data on that. And the question related to that is there any randomized control trial data, CAC-aided management versus conventional management?
Yeah, so I find personally that patients in my practice, if I spend time with them, they are willing to take multiple medications or make lifestyle change because they commonly have a family history or they were concerned about their risk to begin with. And I think an important thing to note here, I always tell patients is I don't always just pile on medicines to my patients. In fact, a lot of them I pull off. I stop the aspirin if the score is 0, for example. So it's not a matter of just I like treating patients with medicines. I just want to treat the right patients with the medicines. And then I think hopefully they get the fact that I'm trying to be personalized with this. And then I like to show them the scan. I like to say that that's why I'm treating you, because you have that in your arteries. And that's what Dad had when he had his heart attack. So I think that's compelling. But we are operating, I'll admit, out of observational data here. We know the calcium score predicts risk. I think most of us believe that risk prediction is a good thing. Most of us believe that high-risk patients get more benefit from therapy than low-risk patients. But as far as a randomized control trial, you have to really think that through what that trial would actually look like. But to a randomized control trial that randomized patients to a calcium score or not, and then either does or doesn't prescribe therapy afterwards and follows them for 5 to 7 years has never been done. It's been proposed and actually turned down by the NIH because of just the complexities and cost of doing this and the shifting of standards of care. So there's some trials ongoing right now that help us with this, but I'm not sure we're ever going to have a trial that like you might be thinking of, because when you actually think about it, this is a very expensive trial with no pharma, stakeholders that we're probably never going to see. So we're still going to be operating out of smaller trials in this notion that, hey, higher risk patients benefit more, low risk patients benefit less. That I think is common sense.
Yeah, I think we have higher chances in trials, like you mentioned, using newer therapies in a select group of high CAC patients, and they will come from there.
Yeah. And then we'll draw conclusions from that. I agree. I'd like to see more of those.
Okay. Thank you very much for the lecture. A pleasure to have you here, and we hope to see you at SCCT, and in that day you'll be there.
Yeah, my pleasure. I hope to meet all of you guys at future SCCT and other meetings, and particularly if you're interested in this imaging and prevention space.
Okay, thank you. Have a great day.